We're going to start with Dr. Pasi. It's my pleasure to introduce him. He's a professor at Harvard, right here at Dana-Farber Cancer Institute in Boston. He is the director of the Belfer Institute for Applied Cancer Science. Sorry if I mucked that title up at all. I think that's pretty close. And he's responsible for some of the third-generation TKI data that I think he's about to share with you. So, Dr. Pasi.
Thank you. Let's see if we can get this going. Okay, so I'm going to talk a little bit about EGFR inhibitors in the setting of acquired resistance to first-generation inhibitors, so Tarceva. And I'll talk a little bit about the clinical data, give you some sort of little bit of historical background of how these sort of came about, and also talk a little bit about where I think we're going, and you'll hear from Melissa afterwards as well. So just in the way of background, as we heard earlier today, for patients that have EGFR mutant lung cancer, this is now giving Tarceva or an EGFR inhibitor is really the standard of care. And the standard of care in the advanced disease setting as the initial treatment, and multiple clinical trials shown here all demonstrate that this is a more efficacious treatment as measured by response or a fraction of patients whose tumor shrinks, as well as prolonging the progression-free survival, duration of therapy before the treatment stops working. And therein, of course, lies the challenge, is that although this is a step forward, these are effective and better tolerated treatments, they don't unfortunately lead to cures in advanced lung cancer. And so that has, of course, led to an intense investigation to try to understand why. Why is it that you have this targeted therapy that's effective against a very critical piece in the cancer, and why can't these cancers be cured? And you heard a little bit earlier in the sessions that, of course, this is because resistance happens. And for EGFR mutant lung cancer, there really is one sort of dominant way in which this happens, and this is what we call the T790M mutation. So this is a summary from the paper from Memorial Sloan Kettering that looked at several different ways, or looked at over 100 or 155 patients that had EGFR mutations, have been treated with Tarceva, and had developed resistance, and their resistant tumor was sampled and analyzed to figure out what was going on. And in the majority of individuals, it's due to this single mutation. And you can see that there are other resistance mechanisms, and again, those were alluded to earlier. Sometimes this mutation is also found in conjunction with a second resistance mechanism. So although most of the time it's more of a black and white phenomenon that we find one, on the other hand, there are instances where more than one thing is going on, and cancers don't have to just develop one way of getting around an effective therapy. They can develop multiple ways simultaneously. So how do we get around that? Well, it turns out that we've known about EGFR T790M for almost as long as that we've known about EGFR mutations. So EGFR mutations were discovered 10 years ago, and EGFR T790M was discovered 9 years ago. This from the publication that was led by the group here locally at the Beth Israel Deaconess Medical Center, where they studied and presented the first patient in whom their tumor was reanalyzed. And at that time of this initial publication, they made a very important observation, is that not all EGFR inhibitors were created equal. And there was a group of EGFR inhibitors, of what we call covalent inhibitors or irreversible inhibitors, depicted here by this tool compound, which has my arrow, just has letters and numbers. What was evident was that in these blots that are here, that even in the presence of this T790M mutation, do you guys have a pointer, by the way? Because the arrow doesn't appear to come up on the screen. Even on in the presence on the right-hand side of this T790M, the drugs seem to be effective. And that led to sort of the next phase of understanding that maybe this class of covalent EGFR inhibitors could in fact be better. And if we look at our sort of first and second generation EGFR inhibitors, there's gefitinib or Iressa and erlotinib, Tarceva, And then the next generation, which are our covalent inhibitors, are called afatinib and dacomitinib. And these are very similar to Iressa and Tarceva, with this one exception that they covalently, they irreversibly bind EGFR. And that allows cancers, or allows one to inhibit EGFR even in the presence of this T790M mutation. Now, both of these agents have been tested in individuals who have developed resistance to EGFR inhibitors. And it turns out that they have sort of a very marginal or very modest degree of efficacy. On the left is the Lux Lung clinical trial. On the right, the BR26 clinical trial presented at ASCO this year. And when patients who had failed EGFR inhibitors were administered these drugs over placebo, less than 10% of patients had their tumor shrink. If you looked at comparison to placebo and measured it in terms of overall survival, there wasn't, in fact, a difference in either one of these. And progression-free survival, i.e. duration of benefit, compared to placebo, was only incrementally better. So an example of, even though there was sort of great potential scientific rationale to take this type of medicine forward, when you actually took it into the clinic, it turned out in this particular instance, in the resistance setting, not to have that degree of benefit. And I think this is a great example of where there is some disconnect between what we think preclinically and what we have learned in the clinic. And the question then is sort of, why is that the case? Well, there is actually a potential answer to this. And so let me try to depict it in this graph here. So if you look at, on the left-hand side, gefitinib or erlotinib or Tarceva, a representative of what we would call a first-generation EGFR inhibitor. At very low concentrations, depicted at 1x in that blue box, you can inhibit mutant EGFR. That's why these drugs are very effective. At a little bit higher concentration, you start to inhibit the normal form of EGFR. This is what gives you toxicity. And at super therapeutic concentrations, you could still inhibit that T790M, but you probably couldn't administer an individual that degree of drug or that amount of drug to actually inhibit T790M. Now, afatinib, which is a more potent version of the same drug, essentially, it's a covalent drug, it does inhibit EGFR, and at lower concentrations, it inhibits the mutant, the T790M, and that's what we saw in those preclinical studies that I showed you earlier. But it's also more potent against the normal form of EGFR. And so you're essentially collapsing this down, and what happens is that the margin between inhibiting a mutant and a wild-type EGFR is very small. And in fact, if you try to administer afatinib to doses that are necessary to actually inhibit T790M, you run into problems and you run into toxicity. And those of you who have been are patients or know of patients who have taken EGFR inhibitors, this is the toxicity that is most troublesome, and it's the skin toxicity. And for drugs that we hope that patients are on for months, if not years, even a small degree of skin toxicity is debilitating. And if you go back and sort of look at this in a timeline and try to understand, well, why was this the case? In all of our EGFR inhibitors, afatinib included, that are in clinical use, were actually discovered in the late 1990s. They were discovered as inhibitors of the normal form of EGFR, because that's what we knew about in the late 1990s. And it wasn't until EGFR mutations were identified several years later that there was the thought that maybe these could be effective in this situation. Thank you. And of course, were tested in that circumstance, but they were never optimized, and they were all, again, discovered before we knew anything about EGFR inhibitors. So this has then led to the opportunity to go back and say, well, can we do better? And can we use this knowledge now and go back to a laboratory-based situation and say, can we identify something that will overcome some of these limitations? So here, just to show you data or laboratory-based data from a preclinical study. This is something that myself and my collaborator Nathaniel Gray published 5 years ago, was that you can actually identify a whole new class of drugs that fit and get around some of these problems. So here is a cell line model, and so the higher the peak, the more resistant the cells are. So here's a cell that has this T790M and is resistant to Iressa. Here's representatives of the second generation drugs, and they're a little bit better. And here's a whole new class of drugs that have a hundredfold. These are 100-fold better than the existing drugs. And they come with a second benefit, is that as opposed to being as good at inhibiting the normal form of EGFR as the mutant form of EGFR, these two properties are now decoupled. And in fact, if you look here, and just to look at these bands here, these are all the existing drugs, and at very low concentrations, you can see that these bands go away because it's inhibited, and here it's much different. You can see here in a mouse model that has an EGFR wild type, not a mutant cell line. Tarceva is very, very effective because it's an inhibitor of wild type EGFR, and this tool compound is no different than placebo because it doesn't inhibit wild type EGFR. So here you can now start to separate these two properties. And again, going back to this graph here, if you separate these two properties, now again you split this wider apart than you see here, and because you're still able to inhibit the mutant EGFR, you can potentially now inhibit both of these without inhibiting the wild type EGFR. And the expectation or the hope is, of course, that with that in mind, you are able to have a drug that's effective against the mutant and spare inhibition of the wild type. And there are now several of these drugs in the clinic. This is a truncated list, but here are some of them, and I'll talk about the bottom three briefly. These come from a different class of medicines. These are called pyrimidines. These are, three of the four are covalent. They're those irreversible drugs that I mentioned to you. And the three on the bottom have actually shown to be efficacious in the clinic. And those of you who are interested in chemical structures, here's the tool compound that I mentioned and two of the clinical compounds. And you can see that they have some structural similarities. So these two are extensively been studied in the United States and around the world in clinical studies. This is the first of them, the AstraZeneca compound. This was studied in a phase 1 clinical trial where patients were, in a typical phase 1 fashion, administered the drug at various doses. But what was unique about the clinical trial was that at the same time as patients were administered higher doses of this drug, separate cohorts of the trial opened where patients who developed resistance or had resistance to Tarceva or afatinib, who had T790M positive or T790M negative disease, were enrolled. And the question is this new class of drugs just as effective in everybody who develops resistance, or does it matter whether or not you have the mutation or not? And if you look at all patients across all the doses, this is in 205 patients treated, about 53% of the patients have a response. So if you remember back to the afatinib and dacomitinib analogous situation, it was less than 10%, so here is 53%. It's a little bit too early to know yet what the duration of the response is, although the longest one here, this is from the ASCO presentation, was greater than 9 months. And you can see that across the different doses, it doesn't really matter, so there's multiple efficacious clinical doses. And if you look at then specifically in the individuals who have the T790M positive, it's actually even higher. It's 64% of the response rate. And again, there's very little differences amongst the different doses, and this is color-coded based on the different doses, and you can see the sort of all over the place. There isn't one dose that appears to be better than the other. I don't have a slide here to show that if you don't have the T790M mutation, the response rate is significantly lower. And in fact, for individuals who are on erlotinib or afatinib and who come off of those therapies and take AZD9291 as their next treatment, the response rate is only 10%. So it would be 10% versus 65%. So there's certainly a difference. It's not zero. And one of the things that we and others are trying to understand is why is it 10% and what can we do to increase that potentially in that population of individuals? But there's clearly a difference there. If you look at the toxicity in this study, it isn't the type of toxicity that we see for afatinib or dacomitinib. In fact, if you look at all the patients, you look at the number of patients in the 232 patients that had to get their doses reduced, it was only 2 of the 232 patients, and only 4 of the 232 patients had a toxicity that led them to stop the treatment. And that's very different than what you see in those other drugs. And here you can look at sort of color coding of the toxicities. Most of them are what we would consider clinically mild toxicities, even across the different doses. And when you do get to the higher doses, you do start to see some toxicities that we typically see with EGFR inhibitors. You see some skin toxicity, some diarrhea, but it's not what we see with afatinib and dacomitinib. And in fact, the middle dose here, the 80 milligram dose, where you don't see a lot of that, is the one that's moving forward in clinical development. The second one of these is one that Leisha Sequas presented called CO1686. This a very similar or analogous type of design, an escalation and a subsequent expansion cohort here. You can see here on different populations of patients, whether they had multiple or therapies or even after just one prior EGFR inhibitor-based therapy. And here, again, a dose escalation schema. The medicine had two different formulations. This hydrobromide formulation, which achieved better blood levels and more efficacious doses compared to this free-base formulation that was given early on in the clinical trial. And here, too, if you have a T790M positive patient, here a very similar number in terms of the response rate, a 58% response rate here in this 40 patient population. And again, you can see that across the doses, there isn't sort of an obvious dose that stands out to say that one is better than the other. And side effects here, again, relatively mild. Very little in terms of rash. Again, the side effect that this class of drugs gets around. There are some side effects, and a unique side effect to the CO1686 is hyperglycemia, or elevated blood sugars, which is not seen with the AZD drug. And there is a third one. This is one made by a Korean company called Hanmi. Again, a similar idea, similar design. And the reason to show this is that there's about 3 or 4 others that are out there that are coming, that are going to enter clinical development. One from Astellas Pharmaceuticals, one from Novartis Pharmaceuticals. So a lot of interest in this type and this class of drugs. Again, the same idea of dose escalation. Patients then looked on how or at what time frame did they progress from their prior therapy. And again, looks like here the actual numerical numbers are smaller, but certainly again here the same idea that if you have the T790M mutation, the drug is more efficacious than if you don't have that mutation. So certainly data emerging on the efficacy of the compounds. I mentioned there are some differences in toxicity, the hyperglycemia or drug-induced diabetes in CO1686. There are some inflammatory changes that have been seen in some patients' lungs treated with the 9291 drug, as well as some skin toxicities, and some pulmonary toxicity that is not clear with the Hanmi compound. And again, these will ultimately all sort out as enough and sufficient numbers of patients will be treated, and depending on, and again, it's a balance between efficacy and side effects. As you heard from Dr. Blumenthal, there is this FDA breakthrough designation. In fact, the AZD9291 and the CO1686 now have this breakthrough designation. And again, our hope is that this will accelerate both of these drugs, making it to the market. So what are our, how do we move forward from here? And I think I'll just mention the last few moments on a couple of different challenges and opportunities that I think we hopefully will be able to get around. One is, of course, how do you best identify individuals that have the T790M mutation? So if the data continues to support the fact that this is a population of patients that is going to have a differential benefit, at least with the single therapy, how do you identify those individuals? And we heard a little bit about the blood-based analyses, and I'll talk a little bit about the kinds of things that we're doing, because, of course, tumor-based analyses are not feasible in everybody. There are places, for example, bone-predominant disease, which is somewhat difficult to biopsy or somewhat difficult to do molecular analyses, or lesions that are hard to access or in a difficult spot where our radiological colleagues don't want to biopsy. So blood testing has some advantages. It also has some advantages in terms of speed, because depending on how quick your institution or laboratory can turn around this test, this can lead to significant delays. And ultimately, and as you'll hear from Dr. Johnson also, is how do you build upon this initial efficacy, even though this class of drugs is effective and it seems to show early clinical promise. I don't think we are under the pretense or believe that resistance won't happen to this class of drugs. But because of the toxicity being lower than it is with Tarceva or afatinib, it does offer the opportunity to build upon combination types of therapies, which to date have been very, very hard to do with Tarceva or afatinib because the drugs by themselves are really at the cusp of being tolerable, and when you add a second or third drug, they become intolerable. So let me talk just briefly about blood-based testing. We use something called digital droplet PCR. This is something that my colleague Jeff Oxnard has developed. And this is an idea essentially of looking for a needle in the haystack. And what you're doing is the needle is the T790M mutation, and the haystack is all the other EGFR copies that come from the tumor or from the normal white blood cells. And the way the technology works is it essentially divides the haystack into 20,000 pieces, and then you're looking at each one of those 20,000 pieces. So as opposed to looking for something that's a very rare event, i.e. the needle in the haystack, when you find 20,000 haystacks, one of those will light up and will have the T790M in it. And it's done using what we call an emulsion type PCR, but the concept is the same, and then there are metrics to try to analyze that. So what that has an advantage for is that it can look for rare events, and because you have a number to it, it can also quantify those events. And so that allows us to get some insight into the biology of the cancer. And we've worked very hard to try to make sure that the test has a very high specificity, meaning that it will not or reduce or minimize the likelihood of false positives, even though that may sacrifice the sensitivity of the test, because if we ultimately want to use it as a clinical test, we want to make sure that when you find something that's positive, it is truly positive. So here's an example of how we've tried to look at this. And so here's a clinical trial of where patients are treated with erlotinib, and a part of this trial is to really understand how resistance to erlotinib develops. And so we collect blood at baseline and during the course of the treatment. And then we can follow what happens in those blood specimens. So here on the left-hand side is a patient who blood is collected over here. And you're looking for the EGFR mutation in their blood, and you can see it's very high. There's 1,000 copies before they start on Tarceva. And when they start on Tarceva, it dips down, but ultimately comes back up as this Tarceva starts to lose its effect. And here's another individual who has less numbers to start out with, and it dips much harder. In fact, it dips to an undetectable level, and then ultimately comes back up. Now, here's the T790M mutation. You don't find it in the beginning on either one of them, but you can see here as the Tarceva starts to lose its effect and the normal EGFR mutation comes up, so does the T790M mutation. And so you can now understand or start to get a sense that in fact you can detect this earlier than clinical resistance would be occurring, and you can get some ideas about understanding of the biology, but it also offers the potential that you can use this blood test now to diagnose someone who has T790M. And could that be a useful situation? And we're trying to pilot this in a few examples, and here's just an example. We showed this at ASCO this year. So here's an example of an individual who came to see us. This is her cancer shown here, progressing on erlotinib. And we're able to draw blood on her. We do this assay, and in 24 hours later, we can tell that there is an EGFR T790M there. And at the same time, the person had a tumor biopsy, and 24 days later, again, reflecting the turnaround time, we're able to, in the clinical laboratory, show that there is a T790M. Patient ultimately went on an new EGFR inhibitor and benefited from that treatment. And this is still a research test, but the idea is that as we move these into the clinical laboratory, this will facilitate, which is what you have to do in order to make clinical decisions, this will facilitate identifying individuals who may benefit from the next generation of EGFR inhibitors and do it in such a way that the turnaround time can be significantly shortened. And so just a final piece then to show on where to go go next. And this is the next stage of clinical trials that are starting to happen with this class of agents, and it's not unique to the AZD compound. But the idea is that can we now use this as a means to combine and add things to an effective therapy? So this clinical trial has 3 arms. They all use the AZD9291 compound. One of the arms, you get a PD-L1 inhibitor from MedImmune. Another arm, you get a MET inhibitor. And as you saw from Dr. Sequa's presentation, MET is a resistance mechanism as well, and sometimes it happens together with T790M, so this combination should be effective. And the third is a MEK, or an MEK inhibitor. And this is a trial that's just starting. It'll be open at the Dana-Farber in about 6 to 8 weeks. And again, Jeff is the PI of the overall trial. And the idea is to figure out, is the combination, number one, tolerable? Is it something we can build upon? And ultimately, of course, is it effective? And does it make the already high efficacy in the T790M patient population even higher? And does it make the efficacy perhaps better in the patients that do not have the T790M mutation? So just to summarize a little bit, there are new drugs in the clinic to treat resistance. They overcome the limitations of afatinib and dacomitinib. And so far, the population of individuals in which they're most effective are those that have the T790M mutation. And the ongoing efforts are to build rational combinations on this, test in both patients that do and do not have these mutations, and ultimately develop assays to find out who's got what, so we can rapidly identify the appropriate individuals that may benefit from either the single agents or the combinations. So I'll stop there.